The last speaker is, and I hope I say this correctly, Jean Fotso. And Jean is a public health researcher with extensive experience in maternal and child health, family planning, and reproductive health. He is also the Associate Director for Research, Monitoring and Evaluation at Concern Worldwide USA, and he's worked in an initiative called Innovations for Maternal and Child Health, and has reached out to different projects in Ghana, Sierra Leone, Kenya, Malawi, and in India. He's also an assistant professor in the Department of Maternal and Child Health at Gillings School of Global Public Health in North Carolina. He's also head of Population Dynamics and Reproductive Health Program at the African Population and Health Research Center, and has many, many other roles which I could go on. So thank you very much for coming and taking the time out today to join us.
Thank you very much. Good morning, everybody, or good afternoon, rather. I want to thank the team here for inviting us to share what we are doing and hopefully contribute to the discussion on this growing field of mHealth. I would like to acknowledge my co-authors here, a number of them, to save on time. Actually, I could skip this slide for this audience. I don't think it would be like preaching to the converted. Basically, the message here is that, yes, the growing field of mHealth provide unique opportunities to increase access to care and improve outcomes. As many speakers before me have said, there are many, many pilots that are ongoing. And the assessment is that the evidence base to guide the development of the field is still limited. I think a number of people in the truth have said that. And this pilot, this project I will be sharing soon, was set up to contribute to that evidence base. On the other hand, focusing on infant and newborn and infant health, again, as a quick reminder, in the late 90s, it became clear that, especially in countries where the health system, the formal health system is poor, a well-designed package of home-based intervention could dramatically improve the health of infant, newborn, and even mothers. But I think the assessment is also that the potential of those home-based program with appropriate linkage with the facility, the potential of this remain largely unexploited, especially in the context of sub-Saharan Africa. So the objective of this study was largely to show whether an mHealth MNCH project, which I will describe very soon, contributed to strengthening this notion of home to facility continuum of care. More specifically, we will be assessing the impact of the intervention on a number of outcomes, child and newborn outcome, and also investigate the extent to which the uptake of home-based care was also contributed to lessening the pressure at the health system. And we are talking of a rural place where even the health system is still not very optimal. Few words on the mHealth intervention itself. The goal was to increase knowledge and use of home-based care and facility-based care for women and children. The project was implemented in Malawi in a district called Balaka. And the mHealth used two components. One, a toll-free case management hotline, and then the messaging system. It was implemented in the catchment area of 4 health centers, which covered about 45% of the district population, implemented between 2011 and 2013. Because we wanted to produce sort of as robust an evidence as possible, the evaluation used a quasi-experimental design with cross-sectional hazard survey at endline, at baseline and endline, and we selected the neighboring district called Shehu as the control site. I have shown here the number of households that visited, about 2,800 households at baseline and about 36 or so households visited at endline. Here are the key variables of interest. I'm just focusing on the one covered here. The home-based care for child health has 3 variables in the data. Of course, limited, but these are the variables: breastfeeding, use of mosquito net, and treatment of diarrhea using ORS. These are the 3 home-based variables that the project was following. Facility-based variable, again, we have 3 of them: full immunization by 12 months, treatment of ARI symptoms, and treatment of fever. And in the analysis that I show very soon, we control for various variables at the community, household, women, and child level. We use different approach, basically for an outcome Y, we compare the intervention at endline minus control at endline minus intervention baseline minus control baseline, the typical double differentiation. And because the intervention was offered but not compulsory, this should be interpreted as an intention to treat. Again, we adjust for various variables here, but key to our analysis is the contrasting the ITT, intention to treat, with the treatment of the treated. Because here we want to control for the selection bias, which correct in a way for the self-selection bias, but due to the fact that even in the comparison side, not all women will have used the intervention, even if they were offered. And we'll see that the difference between the two will be quite wide, and we will discuss the implication. So very briefly, I will just show this. This is just the very simple difference in difference, no control here. I stand for intervention, C stand for control, and this is baseline, endline, and then basically this minus this minus this minus this. Then we have then the simple difference in difference. What we see here is a very small positive effect on breastfeeding, very small. A somehow negative effect on bed net use, but of course, it does not mean that the bed net use decreased. It increased, but it increased less than in the control, so that's the negative effect. On the facility-based side, we have a very strong negative effect on fever. And I forgot to mention, I should have mentioned earlier, that this variable actually, because the fever can be treated at home or at facility, we are using that variable to assess whether the uptake of home-based care also sort of resulted in lessening the visit to the facility for fever. So, as we had sort of hypothesized, a very strong negative effect on visit to hospital for fever among children, and largely no effect on immunization or treatment of ARI. Now, this is the more comprehensive sort of set of results. Here we have control for the variable I mentioned earlier, and we are contrasting the ITT, intention to treat, and the treatment of the treated. I should point to you, I didn't want to go into detail, that the awareness at baseline, at endline, was about 77%. So among all people who were interviewed at endline, about 77 had heard about the intervention in the intervention side. And out of these, 24% had used the services. So overall, I would say about 80% of the population in the intervention side had used the intervention. So again, ITT result, TOT effect. I'm putting here the subsample to which each estimate applies. Here we can see a very strong and positive effect on aggregate home-based care, and which is driven largely by use of mosquito net, because there is almost no effect on breastfeeding. Neither on ORS. The effect I mentioned earlier on the treatment, facility treatment for fever is confirmed here in both the ITT and TOT, very strong and negative effect. which, from the qualitative investigation I did not want to dwell on, confirmed that mothers saw the service as a way to screen. We first call the hotline, and if the case is serious, then only then we go to the health facility. So to conclude, I think we have sort of contributed to the evidence based on how mHealth can affect health outcomes. Our results show that this intervention improves home-based and facility-based care for mothers. I did not show the result, but we have other results for maternal health. It improves use of home-based care for children, and by reducing the unnecessary visit to facility for treatment of the fever when it could be managed at home, it has contributed in a way to strengthening the home to facility continuum of care. The difference that we see between the ITT and the TOT estimate, which in a way is driven by the fact that only 18% of people use the facility, suggests that, you know, if an intervention like this one would be scaled, effort should be made to ensure high enrollment. The higher the enrollment, the smaller the gap between the ITT and the TOT. The project was implemented by Village Reach in Malawi and funded by the Bill and Melinda Gates Foundation. The research was carried out by a local partner called Invest in Knowledge. Thank you for your attention.